Ladies and gentlemen, welcome to the Slip Safety Show. My name's Christian Harris and my guest today is Dr. Andrew Kemp. Andrew is a decontamination and disinfection specialist. He's got a PhD in this and he works for a number of organisations as infection control specialist, including BICS, the British Institute of Cleaning Science. This is a fascinating interview, particularly given the context of what's going on in the world right now with the coronavirus pandemic. And Andrew's got some very strong views indeed about what should have happened with this and what needs to be done to improve things. So we talk about that, what's the WHO doing, what's PHE doing, well or otherwise. We also talk about what can people practically do to understand whether or not their cleaning regimes are being effective, and what disinfection practices they need to take. We talk a lot about different testing methods and give some tips and advice for what people should be doing. I'd certainly recommend listening to this if you've got any interest at all in making sure your buildings are clean, safe and hygienic in these challenging times. As always, if you enjoy this show, please give us a like and a comment, and we'd welcome any subscriptions which will help to keep you up to date when new episodes are released. With that, let's get into the very, very interesting discussion with Andrew Kemp. Andrew Kemp, welcome to the Slip Safety Show.
Thank you. Nice to meet you.
Yes, good to speak. We've had lots of emails over time, but first time we're actually putting faces to names and so on. So yes, it's good to see you in our new Zoom electronic world, the new normal.
Yeah.
So do you want to give the audience a bit of an overview of kind of who you are and what you do? I know it's quite a long list, but perhaps some of the headlines.
Oh crikey! Yeah, I'll keep it short. I think. Yeah. So currently, I'm the head of the scientific advisory board for the British Institute of Cleaning Science. I'm an antimicrobial resistance ambassador for the UK. So I deal with bacteria that are resistant to antibiotics and disinfectants, and I consult for companies doing testing of products and methodologies, etc., to make sure that they're efficacious. And there's a long list of companies getting longer all the time for that kind of testing.
Yeah, and I first came across you, and I think first contacted you when you were doing a talk, I think at one of the facility shows or something like that, which I caught the very tail end of, and I thought, oh, that's really interesting. I'd like to know more about this. And I think that's when we started, because the whole testing of efficacy, as you say, that's something that's very, very important and very topical right now, isn't it?
And sadly lacking. Yeah, it's
somebody. My cat. I'm on the phone, Rolo.
Somebody wants to be in on the conversation.
Desperate for some love. We'll leave that in. That's fine. It adds a bit of colour to things. Lacking. I mean, there's lots of claims of X, Y, and Z, particularly around the whole coronavirus thing. I mean, but not much evidence.
We need to get into that. Really seriously get into that, because that's done very, very badly. There is a duplicity, a double standard that's been. We can get into that now if you want and clear that lie.
Yeah, let's do that. Yeah,
there is a double standard being allowed currently. So that I think the most important thing to say is that most companies currently will be using chemistries that have been tested against surrogates, so viruses that are similar to COVID-19.
Yeah.
Well, in a non-life-threatening situation, that's probably okay, because you can make your best guess as to if that chemistry kills bacteria A or virus B, then it'll probably kill bacteria C and virus D. You can do that when it's non-life threatening and non-critical.
Yeah.
in this instance, not only is it a life-threatening illness we're talking about that is killing a high proportion of elderly people, and we're all very concerned about that, it's also crucifying our economy.
Yeah.
And so it is no longer sufficient to say it might, it probably, it could, best guess. You know, it's 2020. We've been into this for 6 months now. There are testing methodologies available, and coronavirus has been into virtually every clinical lab in every hospital, I would imagine, in Western Europe and Southeast Asia, North America. So there's been lots and lots of coronavirus available for clinicians to test, and yet very few products and very few chemistries have been tested directly against COVID-19. This all stems from really poor regulatory and really poor health advice coming out of the WHO, CDC and Public Health England, amongst others. And the advice is based on a statement that the EPA made in 2016 in respect to coronaviruses, and companies have hidden behind this smokescreen since then. When the EPA made that statement, they were dealing with coronaviruses that weren't particularly harmful, made you a bit sick, gave you diarrhea, vomiting, something like that, but weren't killing very many people. So it's acceptable in that circumstance. And if you frame it in that way, to say, well, if it kills this, it might kill that. And the one that they chose, or one of the ones that they chose, was feline calcivirus, FCV. That is the surrogate for norovirus. You know, we all hear about norovirus because of cruise ships, and it does affect hospitals and sometimes, you know, workplaces, etc. And everybody goes off for a couple of days with sickness and diarrhea. The reality is, in 2018, the cruise line industry, who have very, very deep pockets and can pay for a lot of testing to be done, tested a lot of products that had come to them claiming kill on norovirus, human norovirus, based on killing feline calcivirus. And they sent those testing, those products, etc., to the University of North Carolina, I think it was, who then tested them against human norovirus and found that they failed. So they were killing the surrogate quite easily, but the actual virus that the surrogate was supposed to be so similar to, if you killed that, then you killed the human norovirus, it didn't kill the human norovirus. So based on that, you'd have to say that in 2020, a virus that is killing people should not be in the same category. You should not be, and the CDC, the WHO and Public Health England, amongst others, are negligent if they don't right that wrong. In my view, they are negligent. They are there to help and protect the world, in the case of the WHO, the worldwide population. Just about everybody in the world that's anything to do with microbiology listens to the CDC and what they have to say, and Public Health England for the UK specifically. We haven't heard anything really from the Euro CDC, and most people actually don't realise there is one because they're that quiet. But the reality is that there's lots of this virus around for people to test against, and they haven't done it because they don't need to. They can, because they're allowed to, they can claim kill against feline calcivirus and one or two others and say, because we kill that, we probably kill COVID-19. Not good enough. In 2020, that is not good enough. It's not sufficient, and it is not doing what these organizations are supposed to be doing, which is protecting us. They should, their aims and their roles should be able to advise us on the most efficacious and safest products to use for both skin cleaning and so hands and surfaces. So the only saving grace that they've got is that they maintain amongst them all the washing your hands is the best thing to do. So that's the only reason I'm not jumping up and down at them. And to be fair, nobody listens anyway, because you can argue. Well, I mean, the reality is I've written to the WHO, the head of the COVID-19 task group at WHO. I got a very nice email back, thank you, etc. I'll put you in touch with the right people, etc., who are all listed on the email. I subsequently emailed, but when you face a wall of silence, the same with Public Health England and CDC and governments, etc., you just face a wall of silence. You can't have and you can't engage in a discussion. I have no idea who it is that is advising on disinfectants and disinfecting chemistries in our own government. My guess would be a microbiologist.
Which is worrying.
It is. It would probably be a microbiologist or a virologist. Well, actually, you can count in nanoseconds the amount of time that they spend doing formal lectures or receiving formal lectures or formal teaching on disinfecting and disinfecting technologies in their qualifications. So it's only people who have actually done that. It's not a basic qualification. If you're a virologist, it's a very high qualification. But then they must go on and actually learn about the disinfecting chemistries in order to be able to talk about them. And I have no idea, who is doing that and what their background is. And the reality is, because you can't engage directly with these people, you end up, just as I do, writing articles that say, where is this coming from? How can this be? It's wrong. It's really, really wrong. Now, the reality is that these chemistries may well kill COVID-19. They might. But that's not sufficient when it's killing not just people, but the economy. So it's doing two things to all of us that these organizations like the WHO could have put right. So what should have happened, in my view, and what I'll be pushing for very, very hard after this is all quietened down, is that in future, and these novel viruses come around about every 3 years, if you think about SARS-1, MERS, swine flu, etc., bird flu, they come around about every 3 years. I first dealt with these in 2002, 2003 in Hong Kong with the SARS-1 virus. And so we know that there's another one coming down the pipe in a few years' time. We don't want to make the same mistakes that we've done on this one. What should have happened is when this new novel virus was identified, the WHO should have opened a drawer what to do in the event of new novel virus. Send samples to pharmaceutical companies to analyze to see if there's an antiviral, send to pharmaceutical companies to see if they can start working on a vaccine, send to chemical labs in order to test the 5 main disinfectants that we use and the 3 main hand sanitizing chemistries that we use. That could have been done in January. And you and I would now be talking from a completely different perspective, saying in January, these were tested. This was the best, that worked best, most rapidly. This was second, and so on and so forth. As long as you pick from this list, you know you're killing the virus. But here we are, you're talking to me because I'm supposed to know about stuff like this. And, I'm sitting here as ignorant as the next person as to which of these chemistries is guaranteed to kill COVID-19. And that is just a nonsense. You can't get near this virus unless you've got friends in a clinical lab. That's how poor this has been managed by the WHO, PHE, CDC, and the others like it. It's ridiculous.
Yeah, I mean, I saw that from a PHE perspective, the guidance on cleaning non-healthcare settings was changed, I think, a few weeks ago. And when it was first published in March or something like that, it was talking about, disinfection and chlorine products and so on and so forth. Whereas now it talks about using your normal cleaning products. So it's even kind of moved away from talking about disinfection, which I thought was a little bit punchy, should we say. I'm not an expert like you, but it seemed that probably wasn't the most sensible advice.
Fluffier than a fluffy thing on the planet Fluff. Yeah. How is
Something
that?
like that, yeah.
How is that helpful? And because we do, if they know that these chemistries kill the virus, why have they not released the data? My suspicion is they simply don't. They've just sidelined that based on that 2000, and I don't know who in 2016 actually thought that that was a good idea anyway, because I really would not say that. I want to know for sure whether we're killing something, not possibly killing it.
Yeah.
If I were to come to you tomorrow and say, look, Christian, I'd like to give you the MERS vaccine because MERS is similar to COVID-19. So I'd like to give you that. We're not really sure if it works or not. But by the way, I'd like you to go and work on that ICU with COVID-19 patients and no PPE. How happy are you going to be with that? So the double standard is you can go and work in there with surfaces that may or may not be clean, with hands that may or may not be cleaned. That okay with you?
It's not okay with me, no.
It's not okay with me either, and it shouldn't be the situation where we're actually left in that situation where individuals have to make up their own mind. On the BICS website, have not changed at all since the start of all of this. I have said that unless the product has, and you can see a certificate of testing directly against COVID-19, no surrogates, then you should still, after cleaning, consider surfaces and hands to be contaminated. And take the necessary precautions, because that's the only way you can be sure.
Yeah. So clean, following the PHE guidance, use your normal cleaning products. You can't really, you don't really know that that's going to be doing anything.
Okay, I've got one more question for you. And that is, given that their advice on this is so poor, how can you be sure that the rest of the advice that they're giving about this is really good? Well,
that's a very interesting question, and I suspect,
2 months ago, masks didn't work. Now you have to wear them on every journey. When masks were first introduced into Southeast Asia years ago, I remember thinking, why are these people wearing masks? And then I asked somebody locally and said, why do I see people wearing masks? Is this because, there's smog and things like that? No. Anybody with a respiratory infection has to wear a mask. This was the answer. Has to wear a mask. And then we know that they're infective or potentially infective, so we stay away from them. And you could be on a metro in Guangdong or one of the main cities, on their equivalent of the underground, and you would see a person with a mask on, and then a meter around them, nobody. So even at rush hour, people avoided them. So now I would suggest that is a far better way of doing things than telling everybody to do that. Because if I get on a train and I see you're wearing a mask, I don't go and sit near you. Obviously, that's up for abuse. I'd like a table on my own, so I'll wear a mask and I'll just sit. It's a difficult. You have to expect people to act responsibly for that. But simply saying that masks are, and I've seen papers that say that it's airborne and papers that say that it's transmitted through surfaces, and papers that say it lasts for 40 minutes and 9 hours and 72 hours and oh God, And then I look at the test methodologies, and they're using test methodologies that are 30 years old. The EN 14476 test that's being, waved around is not being done on COVID-19. It's being done on surrogates, so that's a negative for a start. And secondly, it uses techniques that really we haven't used in clinical laboratories in this way for 30 years. Yeah, if this was using qPCR, which is a highly sensitive test, then I would say yes. The other thing about it is that this is being translated into efficacy on skin as well, and yet that test, the 14476, is done. It's a surface test. It's virucidal activity of a particular disinfectant, but it's a surface test, and we know that when these viruses are on skin, they're different to kill than they are on a surface where they're just open, because there's oils and fats and etc. on the skin and places to hide. So unless these tests are done on skin, you can't say that your hand sanitizer works. It's really, this is not dealing with space exploration and things like that. This is not NASA technology. It's really simple. This could have all been done in January, and we're sitting here now knowing what works and what works the best.
And since then we've put 2 men into space, which only took 15 minutes to get into orbit, which is impressive to see. And yet we haven't managed to do this, which is strange when it's affecting everybody in every walk of life and every country, and very, very, very strange.
And strangely, because there's two aspects to this. There's the human side of this, so the people are dying, people are getting sick, and etc. Save our NHS and all that kind of stuff, all quite right and proper. And then there's the destruction of our economies because of the lockdown. So if they want us to come out of lockdown and come out quickly, which seems to be the case, and safely, then we need to know what works for sure, not just in case, not maybe. Sorry, I'll get off my soapbox now. Honestly, it's like, you remember those stress signs that you used to put on your office wall? Bang head here. Yeah, that's me. Yeah.
Well, I bang my head as well around the whole slips, trips, and fall world, and this as well. In terms of cleanliness and hygiene and stuff. I do a lot of work in the sort of grubbier end of different sectors. So whether that's a kitchen or a busy entrance of a shopping centre or a hotel bedroom or a leisure centre changing room, and you just see that most of these environments are typically not cleaned very well, and therefore they're grubby, and therefore there's no chance of them being hygienic, to my understanding anyway, if they've got dirt all over the place. It's frustrating.
Difficult one to call that, actually, and I would have added hospitals to that list as well. If there was a recent survey, I think 90% of UK hospitals use visual inspection to determine the cleanliness of a surface. Visual inspection. When I did a lecture to the Environmental Special Interest Group for the NHS, I congratulated them on being able to use a Mark 1 eyeball to determine bioburden on a surface. It's just unbelievable that we would be in 2020 not routinely testing surfaces by anything other than looking at them. In our hospitals, where we know that we have cross-infection, hospital-acquired infections, etc., costing the NHS huge amounts of money that could otherwise be spent on care and treatments.
Yeah. Well, it's an interesting challenge, isn't it? Because cleaning, if done properly and effectively, brings with it, taking that example, and there's many others as well, lots of benefits, which it's kind of, but people don't want to spend money on that for some reason. So you kind of cut money in this budget here, but spend loads of money over here. Whereas actually, if you spend a little bit more here and did it properly, you'd save massively out of the other pot. And it's getting that joined up thinking is difficult.
Prevention is, what's that? 1 ounce of prevention is better than a pound of cure. I can't remember who said that. It was somebody like Thomas Jefferson or somebody like that, I think. Abraham.
I like that.
And it's very true. It was true back then, and it's true now. For me, the best healthcare system in the world is Cuba, because they were prevented from getting hold of medicines by the trade embargoes imposed on it by the US. They had to do something else to keep the population healthy, so they started on preventative And so, from kindergarten onwards, children are taught about healthy eating, exercise, diet, and hygiene, right from a very early age. And when you look at their statistics for illness, etc., it's a very, very healthy population there. So, prevention definitely is better than cure. No question about it at all.
Yeah, no, absolutely. So in terms of then the testing, obviously there's we should be doing some laboratory testing to figure out the efficacy of different chemistry and so on, disinfection. But at a more local level, let's say someone's watching this and they're, I don't know, they manage a restaurant and they want to open in a few weeks. What could they be doing as a bare minimum that's going to give them a better chance of being safer than not, if that makes sense, if that's a question that can be answered?
Yeah, well, there are two aspects to that question from me. Firstly is what testing should be done on chemistries before they're released onto the market. So that comes down to the regulators and the regulatory authorities, which again, here in Europe and in the UK are really poor. Really poor. The regulations around disinfectants and disinfecting chemistries were put together by a 6-year-old with a box of crayons. They're really poor. And we need to get back to what is right and relevant for this. So what we're interested in is the safety in use and the efficacy in use, and then also the environmental impact. None of which seem to appear in any great store or priority in the REACH regulations, the biocide product regulations, etc. It's just a way of collecting taxes from companies. So make it as complex as you can, so that you have to employ huge numbers of people to wade through vast quantities of bureaucracy. Whereas when you go to places like China and you see what they do, they ask 3 basic questions. So what is it you're claiming this product will do? Claiming it's a hand sanitizer. Fantastic. Prove that it's a hand sanitizer that's effective. Here's a list of bacteria, here's a list of viruses that we want you to test against, and we want you to test using this test methodology, which happens to be a very, very modern and accurate test methodology. So you go away and do that. And then the last part of that is prove that your chemistry doesn't ruin the planet, which is actually a bit of a laugh, clearly, with China and how they are, using coal-fired power stations, etc. But nevertheless, you still have to do that. So that's what they expect. Over here, what happens is that they want you to fit into a square box or a round box or a triangular box. If you arrive with a hexagon, then they don't know what to do with it. Well, it's close enough to a round box, so we'll try and ram the hexagon into the round box and see if it fits. Right. That's ridiculous. It's ridiculous because what it does is it stops development of new products. I was having this conversation with somebody from the US a few days ago about how regulators are actually getting in the way of innovation and progress. The disinfecting chemistries that we use today, all of them are 60 years old or more. All of them. So the basic chemistry, they might have, it was a green box back then, it's now a red box today, but it's still a box and it's still made from the same stuff as the green box. It's just a different color. 60 years old. So you have to ask yourself, why are all our disinfecting chemistries 60 plus years old? Well, if you're a new chemical manufacturer and you start to develop new products and your regulatory frameworks don't allow for that, then you can't get your product to market. If you can't get your product to market, you can't make any money from it. What's the point in developing it? Currently, we have the biggest crisis on this planet is not COVID-19, in my view. It is disinfectant resistant and antibiotic resistant bacteria. Last year, for the first time ever, antimicrobial resistant bacteria killed more people than influenza A. So influenza A estimated at 650,000 deaths, and bacteria that are resistant to antibiotics, disinfectants, AMR, 700,000. So, which is, I believe, about twice what COVID-19 has killed so far in 6 months. So, and that is rising. Yeah. Now, one of the things that we've discovered is that actually, if a bacteria becomes antibiotic resistant, it will become disinfectant, or is more likely to become disinfectant resistant, and vice versa. Right. So we talk about antibiotic stewardship and making sure that people take the medicines that doctors prescribe them correctly, etc. And we don't do anything about disinfectant stewardship. But if the resistance, so if a bacteria becomes resistant to a disinfectant, which makes it resistant to an antibiotic, then developing new antibiotics is almost a thankless and pointless task, because if that's not where your resistance is coming from, it doesn't matter how new your antibiotic is. The resistance will be built because somebody didn't use their chlorine bleach at the correct strength or in the correct amount. So we have to look after both things. This comes right back to these regulatory testing has to be done correctly, and it's not. And the regulatory frameworks have to allow innovative new products to come in, combining chemistries. I don't know whether it'd be possible, but if you take 3 main disinfectant chemistries, if you take a quaternary ammonium compound, hypochlorite, and peracetic acid, for instance, and tried to combine them into one product, I don't know whether that's possible or not. I've never tried it, but if it were, that would potentially produce a very, very active disinfecting chemistry. There would have to be a ton of testing to do that. It'll never happen with the current regulatory frameworks, because anybody that's sitting there thinking about doing that will look at what the regulatory framework will do to them if they actually appear with a cyanide quaternary compound, a hypochlorite, and a peracetic acid all in one product. Goodness me, it would be an absolute nightmare to get through. It would cost more than the development of the product.
So commercially, they just would never bother.
Which is why we don't have any new disinfecting chemistries. They're developing new antibiotics, although that is on the decline. They're developing new antibiotics all the time because there's money in that, but there's no money in this because of the regulatory barriers. And if the regulators then turn around and say, "Nah, it's all right, if you kill this one, we'll accept that you kill that one," well, why bother testing on the actual when you can do it on the surrogate?
I suppose as well, from a cleaning perspective, there are only certain sectors, environments that, in my experience anyway, that go down the route of disinfection, whereas there's a lot more sanitization that happens on a more frequent basis. So I suppose again, commercially, the market for that hasn't been there historically.
And so the second part to the answer to your question about testing is outcome. So if you're cleaning a swimming baths or a leisure centre or a gymnasium or something like that, how do you know that your cleaning has been effective if you don't test it? I think it comes from a business. It was a guy in business, and he said, if you can. Crikey, I'm trying to remember the quote. It was something along the lines of, if you can test it, you can improve it. So
the reality gets managed or something like that,
That's it, if you don't measure it, then you won't improve it, because you'll just accept. So it's a two-phase thing, cleaners and cleaning companies use products that the regulators have said it's okay to do that. They then go to their customer and use those products. Nobody tests to see whether or not in that particular instance, in that particular place, it actually worked. Because it's never been done. People haven't thought about doing that for whatever reason, or they've not had the ability to do it. So they just don't.
Yeah.
Can't think of many things now in 2020 where stuff really isn't tested for.
Yeah, and that's kind of endemic in the cleaning industry. It's
Yeah.
there are so many degreasers, for example. You can buy thousands of chemicals that say they're degreasers, and you take them into a real kitchen and try and clean a floor with them, and you get such varying results. And you think,
Yeah.
well, this product, it says degreaser, this one says degreaser. They're
Mm.
acting in totally different ways. So there's something there that isn't quite right. I mean, what would be the best way of practically trying to measure then the efficacy of a cleaning regime, and then potentially a disinfection, in the real world, in a leisure centre, for example?
Well, the first thing to do is a risk assessment. What do I need to do here? Do I need to disinfect this? And if so, why? So in the case of a leisure centre, you might be concerned about warts, foot warts, or things like that, stuff like that. And in which case you need to decide on the floors, you need a disinfectant that will kill viruses that cause foot infections and warts. You might also be worried about fungal foot infections and being passed on. So is the same product going to kill the fungus that I'm concerned about? So that's the first thing, it's a risk assessment. So the floors are one thing. So what about locker handles and door handles on toilets and in the public areas, etc. So you then have to decide what you're going to do for your high surfaces. What products are you going to use? The next thing you need to do is determine from how the products are what the manufacturer's instructions are, how often to use them. So if you use a disinfectant on the floor, how long is it going to stay around for and keep killing? If you're going to use it and 10 minutes later it was as if it was never done, and somebody walks on it who's got a fungal foot infection, what do I do there? So that's based on risk assessment. The other thing you need to consider is, if I'm using a disinfectant on the floor, are there grease, likelihood of grease and oils, fats, that kind of thing on the floor? Well, yes, because that's from human skin. That's a normal skin scaling things that will come with oils, etc. So I need to do a two-stage clean in that case. Disinfectants will not generally work particularly well on where there are oils and fats. You need a detergent to do that. If I use a detergent to do that first, do I then need to disinfect? Because if I've used the detergent correctly and I've decontaminated correctly, I've removed
everything from the surface.
I haven't killed it, I've removed it. But unless you test to determine that, you won't know. So you either go ahead with a two-stage cleaning, or you test single-stage cleaning and say, after decontamination, the floor is not sufficiently clean, I then have to disinfect. And the same door handles, etc. So it's a risk assessment. And because this hasn't routinely been done, and because now, above any time really, we're concerned that surfaces will pass COVID-19 on, it needs to really start coming up the agenda as to what's important when we reopen. Now, most of in fact, all of the studies that I've seen so far about COVID-19, the length of time it will survive on a surface and remain viable is questionable, but it doesn't seem to be, I've not seen anything that's more than 3 or 4 days. So if your factory or facility, etc., has been closed for more than 4 days, then when you reopen, all you need to do is a standard clean. It will be more about dust and lint and things like that in the atmosphere lying on the floor. So a two-stage clean using a detergent first, followed by a standard disinfectant, a chlorine type bleach, a peracetic acid, in some cases peroxide based, depending on what it is you're worried about. But that's where the risk assessment comes back into it.
Yeah.
What is it I'm trying
then you've got your then you've got to your sort of benchmark of you're up to a standard, and then you need to check again what's going to be effective at maintaining that standard going forward.
Yeah, just on the BIC's website, I put a guidance to cleaning. You apply your own standards to it, so there's some guidance on standards that you can apply, but basically it looks at all of that kind of stuff. How do I measure dust on a surface? How do I measure lint on a surface? That kind of thing, because it's not natural that somebody who comes along with a bucket and mop will know how to do that, but their supervisor should do if they're trained properly. Yeah, they should be auditing.
Mm. Yes, they should be. Yeah. I'll link to that in the show notes. What about again, using my example of 2 different degreasers, and one of them doesn't seem to really do much. I mean, if you clean a surface to any degree and then you try and disinfect it, would that have an effect, or does it need to be properly cleaned, as in removing all ingrained contamination and stuff? Let's say a tile in a kitchen, or a tile in a toilet, or a hotel bedroom, or a leisure centre changing room, for example. If you've got still contamination within the pores of that surface after you're clean, do you need to keep cleaning until you've removed all of that?
Okay, well, there are 3 areas I'm going to go off a little bit on a tangent now, I'm afraid, but it will draw back to your question. So the 3 areas that I think are probably kept cleanest, in my experience, are pharmaceutical clean rooms, endoscopy departments and suites, anything that's doing that sort of procedure, and sterile services departments. Mm-hmm. All of which will tell you that you have to, the better the initial decontamination, the more effective the disinfection. Yeah. So the better your detergent, the better that you remove all of the things that can get in the way of disinfection, the more effective your disinfection will be. I don't know, it must be 15, 20 years ago, the sterile services teams that used to scrub surgical instruments at sinks with hot water and the equivalent of fairy liquid, at sinks, we have teams of people doing that constantly, scrub brushes, etc., getting that. And actually what was determined was that dishwashers would be a better way of doing that, because it's the same temperature water for the same amount of time with the same amount of detergent every single time. If somebody came along and taught you and I how to clean surgical instruments, and then came back a month later, we'd have different temperature water, we'd have a different amount of chemical in the water, etc. It's back to stewardship. Yeah. So these things need to be determined when you're doing a cleaning contract. If you're responsible, if you're an estates manager or something like that, you're doing a cleaning contract with a company that's coming in to do it, or it's your own staff that are doing it, you need to set out the parameters. This is the amount of water. Temperature really isn't that much of an issue over whether it's a detergent or disinfectant. There was a very good paper out from Holland a couple of months ago where they looked at hand washing. And they said, because everybody says, you use water that's, just still able to put your hands under. But actually, when they did it, there was no difference at all in bacterial contamination after hot water.
My experience from a aesthetic cleanliness perspective is, the same with the detergent. It doesn't, the difference between the water being cold or hot, it doesn't really matter if the detergent's good enough for the contamination and the surface, then it's going to work.
Yeah, absolutely. But you need to, say this amount of detergent in this amount of water, applied in this way with this particular type of cloth or mop head or whatever. It was a little while ago. I think the when we met first, I think that I'd been asked about microfiber cloths, because there were things coming out that you could use a microfiber cloth without a detergent, and when I tested it, that was complete and utter nonsense. So you have to be careful about all of these things. So manufacturers, you know, it's not that they're necessarily being in any way deceptive. It depends on how they're testing. So the test that I used was an extremely accurate test. The test that they used wasn't.
Yeah.
So surprise, surprise, you get a different result.
Yeah. Yeah. It's very interesting, isn't it? And I think, as you say, I don't think people are being deliberately deceptive. I think it's just, you know, a lack of, to be honest, it's a lack of knowledge on this subject. And you know, you've got people out there selling products and services, distributors, for example. You know, they're never going to do any testing. They're never going to check it necessarily. They're going to believe what the manufacturer says. So then you've got that kind of Chinese whispers thing of well, they might start overselling it slightly, you know, because they're salespeople, and you end up in a bit of a difficult position.
Yeah, absolutely. And you know, until more data is collected using more accurate information, I couldn't tell you what's an acceptable level of bacteria or virus on the floor of a changing room in a leisure centre. I don't know.
Yeah.
I don't know. I can give you an idea of what's an unacceptable level. Acceptable level, no, not really.
Yeah. Obviously, less is better, but yeah. So what I mean, are there any tests? So in food safety, for example, we see a lot of ATP testing being used for food hygiene purposes. I mean, is that a good test for people to use if people are saying, well, look, you know, I want to test something to give me a bit of an idea to check that my cleaning and stuff processes is being more effective than not? Would that be useful?
No. I wrote a paper on, actually two papers on testing recently, published last year, I think. The problem with these total ATP tests is they're exactly that, total ATP. They only measure the ATP. So ATP, sorry, for those that aren't aware of this, adenosine triphosphate is basically the battery power for every living cell except viruses. Viruses invade other cells and use the ATP in the other cells, so they use the battery power from the other cells. So that's how what ATP is. But there's ATP outside of the cells and there's ATP inside the cells. The ATP you're talking about, those tests only measure the ATP that's outside the cells and some of the ATP, there's the clue, some of the ATP inside cells. ATP, as I said, is in every living cell. So it's in plant cells, it's in human cells, it's in animal cells, and it's in bacteria. So if I swab with an ATP, total ATP monitor, and look at the results and it says 100, is that 100 bacteria, or is it 100 cells from the, I don't know, the plant that's outside the window that's just blown all of its seeds inside my factory? It's unfortunate that these are used in food industry, because I would ban them from use in the food industry. Even a zero count, so you could say, well, if I get a zero count, then obviously there's no ATP there. No, that's not correct, because it will be hidden in some cells, some of which will be bacteria. What do you do about viruses? If you're concerned about viruses being in there, so for in the food industry on packaging, how do I know that COVID-19 isn't on the outside of the packaging? Likelihood is it's taken 4 days to get to the shop, so it's probably not there. But the point is that these total ATP, as I said to you, viruses don't have their own ATP, so they won't be measuring that. I'm not as concerned about viruses in food manufacturing, to be fair, as I am bacteria. But the reality is that again, sorry, I'm going to go off on a bit of a tangent. Many years ago, I was looking at surgical drapes, the sterile surgical drapes. So when you go to sleep and you're going to have an operation, the surgeon and the scrub team put these sterile drapes around you. And there was a situation in the US where some of these paper drapes had been treated with something to make water run away and that. So they were waterproofing. They didn't call it waterproof. They called it some marketing term came up but it basically meant they were waterproof. So when the drapes caught fire on a patient in California, and they tried to use the water extinguishers, the water just ran away and the drapes continued to burn, and the patient burned to death on the operating table. So those paper drapes were banned in California. When they were introduced here in the UK, one of the questions was asked about this incident that had happened in California. And my answer was, don't let that affect your judgment. And the reason that you don't let it affect your judgment is because actually now we know that all you've got to do is have the correct fire extinguisher in the operating theatre, and then if the drape sets alight, then you can put it out. What the problem was they didn't know that, they didn't understand that, nobody had told them that, so they didn't have the correct equipment. It's exactly the same with this. If you think that something is safe, you won't do anything further to ensure it's safe. So if you use a total ATP and it says 0, you will assume that there is no bacteria there. It's clean, I can move on. And that might not be the case. So you have to take these things and use them, if you're going to use them, with a pinch of salt. And to me, it's a pretty pointless exercise if I don't believe that the result is actually the result. So if you get a 0, I don't believe that it's 0. I'm not sure that there's any value in doing it.
Is there anything else that's coming up, exists or is coming down the line that people could use as an alternative? I suppose what I'm thinking about, Andrew, is the example of a kitchen or a shopping centre or a leisure centre where the floors are or the walls or whatever are a bit dirty because there's ingrained stuff and it hasn't been used for a while, and they're going to reopen the building soon. And what can they do to they accept they need to clean it, then they need to potentially disinfect it or sanitize it, but how do they know that the cleaning method is actually putting them in moving them in the right direction? So is there anything kind of practical that people could do other than does it look cleaner, for example?
There are 3 tests that they could do of varying sensitivity. So the most sensitive is the thing called the live bacteria specific rapid metabolic assay. That's a bit of a mouthful, BSRMA. And basically what that does is it actually measures ATP, but in the course of the test, it removes all of that, what we call somatic ATP, all the ATP from non-bacteria, basically. And it opens up all of the bacteria. So in the process of doing that, it kills the bacteria because it opens up the cell wall of all of the bacteria, releasing the ATP from the inside the bacteria. So you get a specific count of the number of bacteria. So there's a linear graph that shows you, 1 light unit equals 1 bacteria. So if you get a number of 98, then there are 98 bacteria. There might be 99 or 100 or 96 or 97. Does that really make any difference? So the question mark is what does that number really mean? And the answer is we don't know. How risky is 98 in comparison to 980? And it's an impossible question to answer, except to say 98 is probably better than 980. So you use that test to determine 2 things. 1, has my cleaning been effective? So if I've swabbed and I've got 1,000 before, and then I've swabbed and I've got 10 afterwards, that's better than swabbing before, getting 1,000 and 100 afterwards. So I'm going to use the thing that gives me 10. So it's a way of using it like that. The other thing is that the second test that's probably more accessible to most people is standard culture. So basically taking a swab, you put it onto some blood agar plate, and then you put it in an incubator for 36 hours and then bomb. That's what's there. It's not very good for counting numbers of bacteria. In fact, it's terrible for counting numbers of bacteria, but it will give you the species of bacteria that you're able to grow. In the best labs in the world, 35% of the available bacteria will grow. So your sample is 65% out before you start. Yeah. A much more accurate and better sensitive test would be PCR, polymerase chain reaction. Basically what that does is it strips out the DNA for everything that's in the sample and tells you there are, there's Staphylococcus aureus in there and there's COVID-19 in there, because the database tells you that the DNA and the RNA is from those things. So those are the three test methodologies. The one that most people will be most able to access will be the culture. So by using the live bacteria-specific rapid metabolic assay, the BSRMA, first, you can determine where the highest levels of contamination are on a surface and take your swab for culture from there. So if I, choose 6 points on a table and I swab all 6 and I get 1,000 in one corner and 10,000 in the other corner, then because I'm much more likely to get a result from my culture sample from a mass of 10,000 than I am 1,000, that's where I'll take my sample for culture from. So that's the best thing to do, and you should be able to, most people should be able to access independent laboratories to get them to culture. And live bacteria specific rapid metabolic assay, it was developed for soldiers to use for biocontamination in battlefields, so it's very, very simple test to do. You get a result in 5 minutes. It's very, very accurate, and if all you want to know is that the number of bacteria have gone down, that's your one. If you want to know what kind of bacteria you've got, you need to do the two-stage thing. You do the BSRMA and follow it by a culture, because the reality is from surfaces, you're not, the chances are you're not going to get a result from most surfaces that you swab if you use culture, which is why hospitals don't routinely test surfaces, because they know, one, they've got to wait 48 hours for a result, and two, that actually when they get the result, it might be negative anyway, because they couldn't actually grow the bacteria that were on the surface. Doesn't mean to say there's no bacteria there, just means I couldn't grow it.
Yeah, no, that makes sense. Yeah, I think most people, in the majority of buildings, obviously it's different than a hospital, and they don't necessarily need to be a sterile environment, if that's the right word, but I think they want to know that they're moving in the right direction, or at least what they're doing is having a benefit, not a detraction from what they're trying to achieve, which is obviously to make the environment as safe as possible.
Absolutely. So some basic testing will be sufficient for them. But that's why you have to do a pre and post. So you're not really making a judgment call as to whether or not something is safe by doing that. You're just saying that my cleaning regime has worked or it hasn't worked. If I've knocked down the number a lot, then it's worked better than if I've knocked down the number a little.
Because what I see too much of, and I'm sure you'll have seen the same, is lemon pine gels and rat stuff that smells nice but doesn't actually do much cleaning. And we need to try and encourage people to move away from that, whether that's on a floor or a tabletop or whatever, and try and encourage them to be more robust and do some of this testing, because anything we can do to improve it is a good thing.
Places that smell nice, that's good, that's good, but it doesn't necessarily mean it's clean. No. So you're quite right. For me, it's not an either or. You should have a clean place that smells nice. Well,
smell is very visceral, isn't it? And it's actually when people walk into a building, if it smells bad, they're probably likely to notice that before how it looks. And obviously you can't as a visitor to a building know how hygienic it is or isn't. So look and smell are obviously critical to get right as well.
I recently tested, I can't say too much because I'm under non-disclosure, but I recently tested a new form of chlorine bleach, and one of the comments I made afterwards was that there was very little chlorine smell. And that's a double-edged sword for this company, because some people associate that swimming bath smell with hygiene and cleanliness. And so if you've got a tablet that's very effective, as this was, but it doesn't smell like it's effective, in the minds of their customers, it might not be working quite so well, even though actually it outperforms standard bleaches. It's a difficult one.
I'm not an expert on pool chemistry, but my understanding is if you go into a swimming pool and you have a very pungent smell of chlorine, that's because actually the levels in the pool are a bit low, because it shouldn't be that smelly if it's all working well. So I think it's actually a bit of a reverse there, that you wouldn't want it to be smelling that much, really.
But to be fair, it's about people's perception that if you perceive something to be clean because it smells the way you would expect something to be clean, hospitals don't smell clean anymore.
No.
Mostly because they don't use disinfectants anymore. And that frightens me to death. It really, I was recently unfortunate enough to have had to have surgery. When I spoke to the cleaner, as you can imagine, the cleaning operative in the ward, and she told me that they only used a detergent, they didn't use a disinfectant unless there was a specific problem. I was horrified.
Yeah, my youngest son, he's had a couple of bouts of pneumonia, and he's been in intensive care, and I remarked, although I didn't talk to anybody about it, but the cleaning, just, it was pretty limited, to say the least, that I noticed on both visits, even in the ICU, which I thought was a bit strange.
Well, I think it was Buzz Aldrin that was interviewed after he'd been into space, been to the moon, and somebody said, when you were sitting there on the in the rocket ready to go on day one, were you at all worried? And he said, what do you think when you're sitting on top of all of that fuel, and you know that every single nut and bolt was provided by the person who put in the lowest bid?
Yeah.
And it's the same with this. If you don't value cleaning, then you don't put any value on cleaning. You just want the cheapest clean. You want to be seen to be doing what is required, the minimum requirement, but you won't actually go any further if you don't believe that does anything. We started this conversation with, prevention is better than cure. And, if you want to reduce hospital-acquired infections, if you want to reduce cross-contamination in your workplace, you have to do something. And you have to be proactive about it, and then you have to measure it. And if you don't do those things, you won't improve it.
Yeah.
It's simple. Einstein is misquoted as saying, if you do the same thing over and expect a different result, it's a sign of what was it? A sign of mental illness or something.
Yeah, madness or something.
Yeah, something like that. Yeah. So, but that wasn't him that said that. But actually, it's still true. Doing the same thing over and expecting a different result, it's bonkers.
Yeah.
Why would it be different? You have to take some extra measure. But if you don't measure in the first place, how do you know?
Yeah, you're just guessing.
We just go round and round and round, as we are doing now, going round and round and round in circles with no answers, just more and more of the same questions.
Yeah.
So what needs to happen is that across all industries, especially healthcare, they need to start to value and understand the value of proper cleaning and disinfection, where it should be done, when it should be done, how often it should be done, by whom it should be done. There you go.
I noticed that UK Active, which is the industry association for gyms and leisure clubs, they just released their detailed guidance on kind of relaunching the industry and making it safe. And I can't remember the exact phrase, but one of the points they talk about is ensuring rigorous cleaning and disinfecting regimes throughout the facility. So they're, to my mind, they're pointing people down the route of, well, it needs to be, properly cleaned and disinfected regularly, which is a significant burden on what people would have been doing in the past. So I think,
but it's still very broad, isn't it? It's a very grey area. What's rigorous? Yeah, does that mean I just rub harder?
Yeah, well, that's the challenge, isn't it? Because I think what's going to happen in reality is, if you break that into sections, rigorous cleaning. Well, what does that mean? Well, I'll spend 10 minutes scrubbing the floor rather than 5 minutes. But if I've got the wrong equipment and the wrong product and I use the wrong dilution in the detergent, then I'm not going to achieve any more scrubbing it for 10 minutes than 5 minutes.
Yeah, exactly.
So it is. I was pleased to see that they've at least talked about disinfection, because to me, at least, that implies that they need the operators of these facilities need to give them a bloody good clean, because you can't disinfect without being clean. So at least that to me is positive, and that's not really too open to interpretation, that they're going to have to clean them first. So that will have a benefit, I guess.
Well, I'm sorry, I'm a little bit more cynical than you, because what that tells me is that somebody in an office somewhere said we better have a policy on this, go and write one. So they cut and pasted off a load of other websites and stuck it together. There you go, boss. Right, we'll send that out. We've got a policy. Tick.
And they haven't really understood what it means.
Absolutely. Yeah. That's the cynic in me, because I'm just cynical now about all of this stuff.
No problem. So is there anything exciting that's happening in your world that coming up over the next year or two, do you think, or any innovations or different products or anything like that?
No, well, for me, it's exciting in the fact that just before COVID-19 hit, I was starting to get some traction with the WHO and people like that in respect to linking disinfectant resistance and antibiotic resistance.
Yeah.
And I was starting to get people to sit up and listen to that. Unfortunately, that's all gone to the wayside for the moment. But I intend to reignite that once things calm down a bit. And the other thing that for me, it's not, I don't think excitement's the right word, but the thing that I really must do after this is stop the same mistakes being repeated.
Yeah.
We must, in the case of a new novel virus in 2 to 3 years' time, we must test our disinfecting chemistries. We must test our sanitizing chemistries against the new novel virus immediately that it's identified. And as a sideline for that, here in the UK, we have an opportunity from the 1st of January to break away from the European Union regulatory straitjackets and actually do something valuable. We can actually perhaps even show the world how a regulatory framework should be produced. Yeah. So those are the sort of 3 main things for me.
Yeah.
AMR and antimicrobial resistance, because that is just, Dame Sally Davis said a few years ago when she was Chief Medical Officer, if we don't get this right with antimicrobial resistance, we won't be doing hip replacements, we won't be doing knee replacements, heart valves, heart transplants, things like that, because the risk of doing those will be far greater than the risk of not doing them.
Right. Yeah.
That's the first time since the 1940s that has been the case. So we need to get this right, and because they're linked, we need to put disinfectants on the agenda.
Yeah.
And they're really not on the agenda yet.
Okay.
None of the strategic documents from the WHO, CDC, etc. even mention disinfectant resistance. Not even a mention of it.
Yeah, worrying.
It is. Well, they've mentioned parasites,
Yeah.
but they're, chemical resistance to for parasites, but not disinfectants, which is bizarre, absolutely bizarre, and it needs to be changed. But the chemical industry seems to be inert in all of this. They're quite happy to maintain the status quo. So that's, those are my three big things for the next couple of years, really. What about yourself?
Okay. Well, I just think, to me, the cleaning industry, and hygiene and safety and stuff, I think it's all about just trying to get back to basics and do things properly in the first place. I would say. I think there's a lot of talk of, innovation for this and innovation for that, but often these innovations are disguised as cost-cutting measures, and actually we need to be cleaning properly and diligently, as you've said, and we need to be ensuring that we're measuring the output of that and making and checking that what we're doing is actually working. And I think that, to me, is what people should be focused on in my world anyway.
Well, you certainly seem to have the platform to be able to spread the word. So you need to become the equivalent for cleaning and that of the TED Talks, I think, really.
Yeah, that's the plan. That's the plan.
Good.
So in terms of anybody watching this that's interested in this in more detail and maybe thinking, okay, what could Andrew do to help? I mean, what sorts of things could you be potentially assisting anybody with at the moment with getting on top of this better?
Okay. Well, dress sense wouldn't be on the top thing. So, yeah, I think most people think I get dressed in the dark, really.
My wife says that about me too.
So what can I do to help, really? Well, I've got a book coming out, I hope, towards the end of next month. So the art and science of cleaning and disinfection.
Nice.
So hopefully that will be getting rid of some of the myth and legend from that. And at the back of the book, there's the guidance on cleaning standards for everybody, really. I mean, it was originally devised and developed for healthcare, but it can be, aspects of it can be used for just about any industry. So watch out for that book. That's a good thing. And then, I write regularly for Cleaning Matters and for Pathology in Practice and a few other journals, Clinical Services Journal, etc. So watch out for articles on there. But otherwise, there's just me. I'm busy, so I'll help wherever I can. But that's limited to what one person's able to do in the time I've got available.
Yeah, good stuff. Well, thanks very much for sparing some of that precious time to chat today. I think it was really valuable, and although, as you said, we're posing a lot of questions rather than necessarily giving answers, that in itself offers a lot of value, because it explains to people what the real situation is and gives them some guidance on the sorts of things that they need to be looking at and considering themselves. So thank you.
They need to be writing to their MPs and saying, why have we not got the answers to these questions? Why haven't we? What are you doing about it? Why are we paying you if you're not doing these things? So that's what people can do, is they can write to their MPs and say, this is nonsense. Get it sorted.
Get it sorted, yeah. Get it sorted. Good stuff. Well, thanks very much, Andrew. Have a good rest of the day, and keep busy. And I look forward to receiving a signed copy of your book when it gets released.
I'll send you one.
All right. Good man. Thanks a lot.
Cheers.